And Logan, we'll just start with you. What questions do you have?
Well, one of the questions that I had that was she keeps coming up on my NREMT that I've been kind of struggling with is I guess there's so when you're dealing with certain drugs, they have certain drugs that you could overdose on per se,
Of
and
course. Well, you
I
can
guess there's
overdose on
different.
any drug.
Yeah, exactly. So there's different treatments for these drugs. Like I know the common ones like your benzos and all that stuff, but
All
like
right. So hold on. So let's stop. Let's slow it down a little bit, my man. So let's go. You ready?
mhm.
All right. So let's go. My man says he wants to talk about. Hold on. Let's see if we can put you in there with me. There you go. You got my iPad.
Mhm. Yeah.
Okay. Let's go. So let's start off with just common overdoses. Okay. So
Mhm.
probably the most commonly ones that get tested. Okay, it's going to, and by the way, in the Coach Joshua's drawing study guide, if you've signed up at the pro level in the bonus resources, and so in the bonus resources, you get two separate things. I mean, you get several bonuses, but let me show it to you. If I go to classroom, and this is for those of you who have not signed up at the pro level, this is why you want to sign up at the pro level because in addition to the NRMT Pass Study course and the 14-day program, you also get the EKG Mastery Challenge and you get all of the bonus resources. Well, one of those bonus resources, or two of them, is the Coach Joshua's 5-star drawing study guide. So in this one, this is like a whole set of my drawings. In this same drawings one, there's a page on overdoses. Also, in the comprehensive study guide, there's a section on overdoses. So both of those would be great resources to use, especially to make sure you nail all these overdoses. So let's talk about it. The most commonly ones that get tested are, for instance, an opiate overdose. Okay, let's just go down a list really quickly, and then we'll go through them all. So an opiate overdose. Another one would be like a benzo. Okay, maybe a tricyclic antidepressant overdose, an aspirin overdose, alcohol alcohol overdose. Let's say a Tylenol. So that's going to be acetaminophen, or outside of the U.S., paracetamol. All right, so these are some common ones. Let's talk about an opiate overdose. Okay, how does an opiate work? So here's your cell, and here's your receptor. This is the opiate receptor. Now it has a particular name, so it's not really called the opiate receptor. What's the actual name for the receptor that opiates bind to?
That's a
The
great
mu
question.
receptor.
Come on, Garrett. Garrett, you're testing at the advanced level, right?
Yes, sir.
But you're doing the 14-day program?
Yes, sir. I'm finished with it.
Check you out, my man. So you've already heard me say this, right? Through the program?
Yes. Yes.
Uh-huh. Little sneaky guy. I thought he just knew this. Okay, but he is exactly right. It is the mu receptor, and that's going to be abbreviated like that. So that's the mu receptor, spell MU. So what happens with an opiate is the opiate binds to the mu receptor. And then it causes all these symptoms: respiratory depression, somnolence, sleepiness, drowsiness, respiratory failure, all that kind of stuff. Okay. By the way, in an opiate overdose, remember, all problems come to one of three things. They're either oxygenation, ventilation, or perfusion. All problems come to that. In an opiate overdose, what's our primary problem? Is it primarily oxygenation, primarily ventilation, or primarily perfusion? In an opiate overdose, what's the real problem that would kill this patient if we don't act quickly?
Probably be the ventilation
It
issue.
is. It's a ventilation. Well, let's put that in purple. It's a ventilation problem where their respiratory rate gets knocked out. So now they've got respirations probably less. Oh, sorry. You didn't see what I just did. So hold on. Let's move. Hold on. Let me just add a page here so everything shows in the screen. All right. Hang on just a second. All right. Now let's try it. Okay. So what happens is here's your respiratory rate. So our normal respiratory rate is for an adult is 12 to 20 breaths per minute. However, in this situation, respiratory rate drops to below 10. So any number below 10, from 10 to 0 or 0 to 10, all of that is respiratory failure land. By the way, for those of you who've been in the program for a little bit, what's our fix for any ventilation problem for any reason, whether it's opiate overdose, benzo overdose, neuromuscular disorder, anything that causes respiratory failure or any ventilation problem for any reason, for 1,000 reasons, what's the fix for a ventilation problem?
Assisting ventilations.
Okay, we're going
Is it
to
a BVM?
we're going to use a BVM. Do we ever use a BVM by itself?
No, with
No.
oxygen.
What else do we use with the BVM?
We'll attach O2 to it.
There you go. Check you out. It's always O2 attached to it. We always power it up with O2. And what else do we do? If we're using a BVM, we probably also need to be using what?
Capno.
Well, yes, Capno is more for monitoring, but what else should we be using just because we're using a BVM? That's going to be an OPA or an NPA. Now, this is where 950 medics don't do this. 950 medics who just passed the test and are a medic, they just use a BVM. 3,000 level medics who actually know what they're doing, every time they're using a BVM, they also assist with an adjunct, whether that's an OPA or an NPA, whichever one is not contraindicated. Okay, we never use a BVM by itself. It's always the three stooges so it's going to be a Airway adjunct, BVM plus O2. Now, in an opiate overdose where you have a ventilatory problem, what is the actual problem? Like, what's the issue that causes them to die? Because when they're not breathing, they're not blowing off what?
CO2.
So their CO2 levels are starting to rise. What's our normal CO2?
Isn't it 45? It's like 35 to 45.
All right, who's talking, by the way?
This is
Oh, I thought you were talking to me.
this is a Winchell. I don't know how to fix my camera.
Winchell, how you doing, my man?
How you doing, sir?
I'm well. Where are you calling from?
I'm calling from Olive Branch, Mississippi.
Okay, all right, cool. Here, Logan, we'll take you out for just a minute, give you a break off the camera, but okay, so yes, our normal end-tidal CO2 is 35 to 45 millimeters of mercury, and what happens when you are not breathing is you're holding on to too much CO2. CO2 behaves like an acid, and when you hold on to acid, that's going to put you in a state of acidosis. And Garrett, what does acidosis lead to?
Vasodilation.
Man, my man, acidosis leads to vasodilation. So we're going to dilate these arterioles, and then vasodilation ultimately leads to what, Garrett?
Shock.
My man, check you out. So vasodilation leads to shock. So the reason we have to do something for somebody who's not ventilating well for any reason is we have to ventilate them to prevent them from going into shock, okay? Because ultimately what's going to kill them is they're going to go into shock, and then their shock, once they progress, so let's go over that again. When you have too much CO2, CO2 behaves like an acid. That puts them in a state of acidosis. Acidosis leads to vasodilation and shock. Here's what happens in shock. There's one equation to know. It's our blood pressure equals heart rate times stroke volume times systemic vascular resistance. Notice what we're doing here. We were talking about opiate overdose, and I'm already in a shock. It's because everything is related. You need to know how everything is connected. That helps you think through situations on a test. It also helps you think through situations in real life. So let's go back to the situation of shock. How does this patient with an opiate overdose die? What happens is they end up with respiratory depression. So in this respiratory depression, so remember, this is kind of the order of things. We start off with ischemia. Ischemia progresses to hypoxia. Hypoxia progresses to respiratory distress. Respiratory distress progresses to respiratory failure. Respiratory failure progresses to respiratory arrest. And respiratory arrest progresses to cardiac arrest. Okay? Now, but how does it happen? That's what happens. How does it happen? So when I dilate these blood vessels, I dilate blood vessels everywhere, including the brain. So when I dilate blood vessels in the brain, now I have increased intracranial pressure in the brain. That increased intracranial pressure in the brain now starts pushing on the brain stem. In the brain stem is where the respiratory center is located. And when you knock out your respiratory center, now you can't breathe. That's how they go into respiratory arrest. Okay? And now when they go into respiratory arrest, how do they make this jump into cardiac arrest? Well, as they further go into shock, what happens is when we dilate these blood vessels, the systemic vascular resistance goes down. When the systemic vascular resistance goes down, the blood pressure also goes down. When the blood pressure continues to go down, the mean arterial pressure drops below 65 millimeters of mercury. That pressure goes down, and now eventually we don't have enough pressure to send blood to the brain. Okay? And we also don't have enough pressure to flow blood through the heart. And so when we don't have enough pressure to send blood out of the heart or back to the heart doesn't get any blood. And when the heart doesn't get any blood, nothing comes in, nothing comes out. That equals cardiac arrest. Does that make sense? So that was a lot of information. Let's see who could hit me with all that again. Because I never want you to just know what something is. I never want you to just recognize respiratory failure. I want you to understand, how does a patient go through all these steps? There's something happening behind the scenes that makes all of this happen. Christian, I'm looking at you. I want you to hit me with all that one good time. Christian, so your job is to tell me how in an opiate overdose do they ultimately die if we don't do something. So let's start us there. Let's start with an opiate overdose.
Okay, so when somebody has an opiate overdose, the opiate connects to the mu receptor.
Ooh, okay, good.
That mu receptor is then going to lead, well, all of that is going to lead to ischemia.
More specifically, in this case, we're starting at the hypoxia stage.
Or hypoxia, excuse me. That's going to build up CO2. CO2 is going to lead to acidosis.
Okay.
Acidosis is then going to lead to dilation.
What kind of dilation? Vasodilation. There you go. Vasodilation. Okay. Keep going.
And then from vasodilation is going to lead to shock.
Okay. And vasodilation is going to lead to shock. And when you're in shock from all this vasodilation, what does it do to the resistance? When you make the pipes bigger,
it lowers the vascular resistance, which in turn lowers the
systemic
blood
vascular
pressure.
resistance goes way down. And when anything on this side goes down, what also happens to the blood pressure side?
Goes down.
It goes down. And when the blood pressure keeps going down, what happens to the mean arterial pressure?
That decreases so much.
It goes down.
There's no blood.
When that goes down, you don't have enough pressure to pump blood where it needs to go. What's the most important place that blood needs to go?
Brain.
The brain, because what's the brain's two favorite snacks?
Oxygen and glucose.
Oxygen and glucose. So when there's no blood flowing, there's no oxygen and glucose flowing to the brain. Okay. Now the brain starts to, part of it is we dilate some of the blood vessels in the brain. That leads to increased intracranial pressure. So here, let's draw that out.
I was going to ask you that question. I was confused on how there's more pressure in the brain, but yet less blood to the brain. How does that make sense?
It's because so one of the things that the body does to compensate is because it has to keep the brain alive. So inside or the blood vessels going to the brain, those also dilate initially. Okay. But now if I dilate these blood vessels, now I have more blood or more swelling, more volume going to the brain. Well, because there's a skull around the brain, when I keep putting more volume going to the brain and then more pressure, eventually that volume starts to go into the brain stem. Okay. And then here in the brain stem, here's our respiratory center. This part that I'm highlighting, that's the medulla oblongata of the brain stem. That's where our breathing center is. When I keep putting more pressure or more volume that knocks out the brain stem, this now in turn knocks out my respirations. This is how an opiate causes respiratory depression. When I have enough respiratory depression, it's going to lead to respiratory failure, and then eventually it leads to respiratory arrest. Okay? And then because elsewhere in the body, once you don't have enough blood flow, we now don't have enough blood flowing into or out of the heart. That's going to ultimately shift them into cardiac arrest. This is how a patient ends up dying from an opiate overdose. Okay? So in an opiate overdose, our situation is we've got a ventilation problem. And our fix for that is going to be a BVM first. This is why Narcan is not the first fix for an opiate overdose. Narcan, what does Narcan do? First of all, how does Narcan work? Narcan.
Oh, sorry.
Keep going. So here's
it,
Narcan. Well, let's see. Am I on the screen? Okay, this green thing I'm drawing right now. This is going to be our Narcan. Let's call it naloxone. How does it work? Narcan says, hey, okay, keep going.
I thought you were asking me. My bad.
I am.
It binds to the mu receptor so that it blocks the opiate from connecting.
So here's our Narcan or our naloxone. It binds to that same mu receptor. What it does is it prevents more opiate from binding because the seat is already taken up. They both compete for the same spot. So they're what are called competitive. It's what's called a competitive inhibitor. You have two types of inhibitors, competitive and non-competitive. A non-competitive inhibitor attaches to another site, what's called the allosteric site. In this case, this is a competitive inhibitor. It competes for the same site. Okay, so Narcan, all it does is it prevents more narcotic from binding to make the situation worse. But the Narcan by itself does not blow off the CO2 for them. Remember, when they're not breathing, they're holding on to too much CO2. CO2 behaves like an acid, puts them into acidosis, leads them into shock. We got to do something to get rid of the CO2. That's where the BVM comes from. That's why it's the first thing we do. So narcotic, first thing we do is BVM. The next thing we do is naloxone. Okay. What's our dosage going to be for naloxone?
I have a quick question, Joshua.
Hold on, hang on. What's the dosage for naloxone?
All
right, that's going to be 0.4 to 2 milligrams. It can be given lots of different ways. How can it be given?
IV intranasally?
It could be given IV. We typically don't do it IV. Primarily, we want to give it intranasally just because it's very in the nasal mucosa in the nose. In the nasal mucosa in the nose, it's very quickly, it has quick uptake, rapid absorption because there's a lot of blood supply there, so it immediately gets into the bloodstream. We can also do this through, we could even do it IM. We could do it IO. I mean, we can give it lots of ways, but intranasal would be preferable. Okay, Christian, what's your question?
So the times that I've given Narcan before, for somebody like with fentanyl overdose or something like that, a lot of the times you'll give them, the dose, they'll pop back up or whatever and be awake, and then they'll pass back out again and it hits them again. Is that because Narcan has like a less half-life than an opiate, or how does it work where it doesn't stay binded until they're okay?
Yes. So yes, half-life is essentially what's happening. I don't know the exact half-life of Narcan, but what's happening is so let's go back to the drawing. So what's happening is when this naloxone or naloxone is green. So when the naloxone or Narcan binds to the mu receptor, it prevents more from attaching. But the thing is, so yes, you may see some effect, some positive effect where the patient like comes back to life. But what you don't know is, Narcan's in purple, you don't know how much more Narcan is nearby, already in the bloodstream. So there are other, because you don't just have one receptor, you have thousands of receptors. So you can still have other Narcan attaching to other mu receptor sites. Does that make sense? I mean, I'm sorry, other narcotic. You can still have other narcotic attaching to other places. So it helps in some of the places, but it doesn't necessarily address all the receptors at the same time. You've got receptors all over the body. Okay.
So how come we don't give them more than just 0.4 to 2 milligrams if we know we're going to...
Well, we may have to repeat it.
Okay. Yeah.
Yeah, we absolutely may have to repeat it. It's just we start them off with, you want to start them off with the lowest dose possible, because what can happen is you can shift them from an opiate overdose and you can detach so much narcotics so quickly that you now shift them from overdose into now opiate withdrawal. And so now you've got like the opposite effect where they're violent and all of that. They're vomiting and those kind of things. So we want to give them just enough to have the desired effect, but not any more than that.
Copy.
All right, that makes sense?
Yes, sir.
Okay, so first treatment for an opiate overdose is
BVM.
BVM because it's a ventilation problem. The narcotic is just the medication that we're going to use to kind of assist us. Okay, let's go to benzo overdose. So Logan asked for overdoses. Let's go to benzo. What's our drug of choice for a benzo overdose?
Flumazenil.
Flumazenil, also known as Ramazicon. Flumazenil, also known as Ramazicon. Okay, let's say we have a tricyclic antidepressant overdose. What's our drug of choice there? Hey, Winchell, how you doing, my man?
Sir?
All right, unmute for me. Okay, there you go. I got you now.
Yeah.
And so a tricyclic antidepressant? Okay, it behaves like an acid.
Okay.
What's our fix for acid overdoses?
O2?
No, not primarily.
Bicarb.
Bicarb,
Okay,
yeah.
so the very first thing for an acid overdose, when they have too much acid, we're going to neutralize the acid. And the first thing we're going to use to neutralize the acid is fluids. Okay. Now, what fluid would be ideal in this situation? So of our isotonic crystalloids, one of those can make acidosis worse. If they already have too much acid, I don't want to give them something else that's going to turn into more acid. What is the one that causes more acidosis? So let's.
Is it lactated ringers?
That you want to give or don't want to give?
Don't want to give.
No.
I think you want to,
Okay.
yeah, you want to give LR.
All right, so check this out. So you know how we have isotonic crystalloids? We have hypotonic, and then we have hypertonic. Okay, isotonic. So the examples there, that's going to be normal saline, and that's going to be lactated ringers. Those are both isotonic crystalloids.
Okay.
The problem with saline is saline contains, so it's 0.9% sodium chloride. Na is sodium, Cl is chloride. Those two together make salt. Saline contains sodium and chloride. The problem is, here, let's put the sodium part in black. The problem is the chloride. The chloride part leads to acidosis. And we already said that acidosis leads to vasodilation, and vasodilation leads to shock. This is why if you have a patient who's already in some type of shock, let's say you have a trauma patient who's in hypovolemic or hemorrhagic shock, normal saline could worsen their situation because it's going to further aggravate or what's the word I'm trying to think of? Enhance or whatever the likelihood of shock. Okay. On the other hand, ringers is made up of sodium, potassium, calcium, and lactate. Okay. So if you have, so the times where you want to use ringers are going to be major trauma, burns, sepsis. Okay. So major trauma, burns, sepsis, ringers is better than saline because saline has chloride. Chloride leads to acidosis. Acidosis leads to vasodilation and shock. Okay. So if you have any kind of patient in any kind of shocky situation, saline is probably not the best choice. If you have ringers, use ringers. So in this situation, let's go back to where we were. In this situation where you have a tricyclic antidepressant overdose that behaves like an acid, the ringers actually may be preferable. However, in the short time that you're going to be with them, if saline is all you have, that's okay. It's better than nothing. So what we're going to do is we're going to give them some water to neutralize all this acid. So fluids first, and then the next thing is going to be bicarb. So fluids and then bicarb. Okay. Let's say we have an aspirin overdose. Same kind of thing. Aspirin is acetylsalicylic acid. So it's too much acid. How do we fix acid problems? Primarily, we're going to go fluids and bicarb. So that same treatment could apply there. So number one, for an aspirin overdose, we're going to give fluids, and then we're going to give bicarb. Now, I'm not saying these are the first things you do, but I'm saying in terms of like medication treatments, these are the first things you do. It still comes down to, do we have an oxygenation, ventilation, or perfusion problem? And we have to do whatever is going to fix that. In this case, though, let's talk about an aspirin overdose. Aspirin overdose, not only the reason it's so problematic is it causes some big time acid-base disturbances. So let's talk about an aspirin overdose. So we have an aspirin overdose. Initially, in the early phase, it causes one acid-base problem, but then later it causes another acid-base problem. What's that? Anybody know? Alex, you know this yet?
No, I don't.
No problem. Okay. So, Cody, are you seeing my screen now? Is everybody else seeing my screen?
I see it.
Okay. All right, Cody, it may be just your device. What you can do is exit out of the Zoom room, come back into the Zoom room, and see if that fixes your screen issue. All right, in an aspirin overdose, the very first thing that happens when it comes to the acid-base disturbance is early on, it leads to respiratory alkalosis. Okay? In respiratory alkalosis, how's your pH going to be? If it's alkalosis, pH is going to be what?
High.
All right, so pH is going to be high, so that's going to be greater than 7.4. Okay, now because it's a respiratory, remember in respiratory situations, pH and CO2 go in opposite directions. So if pH is high, then that means the CO2 goes down. And when I say going down, that means, so remember on our acid-base thing, and I did a whole video on this, we're going to put 45 on the left, 35 on the right. When it goes down, it means that it's less than 35. Okay, so that's our CO2. Aspirin overdose in the early phase causes respiratory alkalosis, and in the late phase, it causes metabolic acidosis. Okay, speaking of metabolic acidosis, what's our mnemonic that we're going to use, our acronym, to figure out most likely causes of metabolic acidosis?
Is it Rome?
No, Rome is what we're going to use to figure out respiratory opposite, metabolic equal. That just helps us figure out pH compared to bicarb or pH compared to CO2, which direction they go. Do they go in the same direction or not? That's Rome. But for metabolic acidosis specifically, what's our acronym there? All right, so this is going to be mud piles. Some people use gold mark. I use mud piles. So what are our causes of metabolic acidosis? Most common causes. M is methanol. So that's going to be alcohol. So methanol. U, tell me what's the U? All right, so all of you, so most of you are paramedic students, and you need to immediately be able to know these answers. So if you're in our program, you want to make sure that you're doing those rapid drills. If you're not in the program, you need to get in the program, because this is why I say you don't want to be a 950 medic. 950 medics just memorize stuff they heard somebody say. You need to be a 3000 level medic who really knows what you're doing. So, because if you have a patient who has suspected metabolic acidosis, you got to figure out why so that you know how to treat it. Now, the U, that stands for uremia. So that's probably a kidney problem. The D, it could be diarrhea. It could be several things that start with D. The P, what's the P? Anybody know? Okay, this is going to be propylene glycol. Propylene glycol is in lots of things. It's in lots of medications. It's in blood transfusions. Lots of things have it like as an additive. So lots of medications could have this or could lead to this because they have this ingredient or this waste product in it. What's the I? The I is going to be an iron overdose. Isoniazid. Isoniazid is a drug that's used for tuberculosis. The L, this is going to be lactic acidosis. So this is primarily going to be our septic patient. The E is ethylene glycol. Ethylene glycol is a big ingredient in antifreeze. So antifreeze or de-icing solutions for windshield, things like that. And then the S is salicylate. So that's going to be like your aspirin, okay? Salicylate toxicity. Okay, you want to know this. You want to know your causes of metabolic acidosis. So let's kind of recap where we were. We were talking about aspirin. Aspirin is acetylsalicylic acid. So when you overdose on it, it can eventually, this is how it's going to eventually put you in acidosis. But it doesn't start there. It actually, one of the first acid-base disturbances you'll have is respiratory alkalosis. But then later, as you keep hanging on to it, then it's going to progress you into metabolic acidosis. And what have we noticed so far? Every time I've said acidosis, I've also said any kind of acidosis leads to what and what? Just unmute. Acidosis leads to anybody?
Vasodilation.
Vasodilation leads to shock. Okay. So this is how anything can lead to cardiac arrest. Because if I have shock, as we went through earlier, any kind of shock for any reason, we drop the systemic vascular resistance, or we drop the blood pressure, we drop the mean arterial pressure. Now we don't have enough pressure to send blood to the brain or to the heart. Okay. And that combination proves to be deadly, because that is exactly what's going to put them in the cardiac arrest. All right. So let's go back over this. So far, we said opiate overdose. We're going to use Narcan or naloxone. How does naloxone work again?
It's a competitor for the receptor.
Which receptor?
The mu receptor.
Okay. Yes. Naloxone or Narcan is going to bind right here to the mu receptor, spelled mu. This is the Greek symbol mu. Okay. But is Narcan the first thing we do?
No.
No. What's the first thing we do? Because it's a ventilation problem.
It's our three stooges. It's going to be our
three
BVM.
Stooges, we got a BVM plus O2 plus
OPA.
Nice.
Yeah.
Benzo overdose. What's our treatment of choice for that, if you have it?
Flumazenil.
Flumazenil, also known as Remazicon. For a tricyclic antidepressant overdose, what's our treatment of choice?
Sodium bicarb?
Do we start with bicarb?
No.
Do we start with? What's the simplest
Fluids.
thing we can start with? We go simple before complex.
Lactate
Easy
and
before-
ringers.
So we're going to go with fluids. The preferable fluid in this situation would probably be ringers. We're going to go fluids and then bicarb. Okay. Same for an aspirin overdose. We're going to go fluids and then bicarb. Okay.